Bismillahirrahmanirrahim. This is the second part of the left to right shunt lesion lecture, anesthesia for left to right shunt lesion. We'll talk about the VSD. Okay, VSD, the ventricular septal defect. So this is a defect in the interventricular septum. There are 4 types. The nomenclature of the VSD is a source of confusion between physicians because there are many names and some names refer to the same type. So and some echocardiologists they use a name and another one uses another name, so it is a source of confusion. So we can divide them into 4 types. To start with, there are the muscular type 4. The muscular can either be mid-muscular or apical. Sometimes the muscular is outlet and sometimes it is toward the inlet, but it's still muscular. There are muscles around the VSD. So type 4 is muscular. Type 3 is the inlet. It is related to the tricuspid and the mitral, and it is usually associated with the AV canal, either partial or complete AV canal. So it can be called inlet VSD or canal VSD. The outlet, type 1 and 2, are both outlet VSDs. The outlet VSDs are 3 types. Either muscular outlet, like this one, so it is muscular but towards the outlet. We can find it in the middle. In the later slide, we'll see the difference between the 3 types in the RV inflow outflow view of the transesophageal echo. But here we can say that the muscular VSD, if it is towards the outlet, so it is called the outlet VSD, and it is considered type 4, muscular. Type 1 is the subpulmonic. This is the most common name, subpulmonic. It is related to the pulmonary valve, just under the pulmonary valve. Sometimes called subarterial, sometimes supracristal. This is the crista terminalis. Crista supraventricularis. This crista, if the VSD is above the crista, it is called supracristal. Fundibular conal. All these are names of the same thing. And this is the perimembranous or the subcristal or the paramembranous or the conoventricular. We find it is a VSD that is an outlet, but it is related to the tricuspid valve with almost no tissue between the tricuspid and the VSD. Almost no tissue. So it is very close to the aorta and the tricuspid valve. This is the perimembranous. We find it in fallow cases. So these are the types of the VSD. Type 1 is the subpulmonic, type 2 is the perimembranous, type 3 is the inlet, and type 4 is the muscular. This is the nomenclature that I will use and that I am used in practice. May be associated with trisomies, the syndromes Vactrel and Charge. So we have to be minded with these conditions that may be associated with a difficult intubation, difficult airway. Preoperative assessment, like the general considerations that we talked about in the previous lecture, we assess the number, size, direction of blood flow and gradient across the VSDs. VSDs cause left to right shunt during systole with volume and pressure overload on the pulmonary circulation. So in the ASD, there was diastolic volume overload on the right side. But here it is the systolic volume and pressure overload on the pulmonary circulation. So the pulmonary circulation under much pressure, whether volume or pressure, so pulmonary hypertension develops more quickly. Left-sided dilatation, because more blood comes from the lung to the right, to the left side, so left side receives more blood, so it dilates. Fall in neonatal pulmonary vascular resistance worsens the symptoms. History of low cardiac output and failure to thrive, congestive heart failure. Sometimes these patients, they don't grow, they become cachectic, and intervention is urgent in these cases, should not be postponed. Restrictive VSDs are less severe. In cases where the VSD is sub-aortic or subpulmonic, like in those cases, sometimes the right coronary cusp gets prolapsed due to the Venturi effect of the jet of the VSD, the blood passing through the VSD. If the VSD is restrictive, so the blood flows with high velocity, causing negative suction and right coronary cusp prolapse that may further restrict the VSD and may close it completely, or causes it to becomes even narrower. But aortic regurg may develop, and it renders the operation difficult because if the aortic regurg is severe, it should be addressed. But in children or even infants, it is difficult to repair the aorta and to replace it. Sometimes the jet, if the VSD is restrictive, the jet bombards against the free wall of the infundibulum, causing thickening of the wall, the free wall, and subvalvular pulmonary stenosis or double chamber RV due to hypertrophy opposite the VSD jet. Okay, in this diagram, the VSD, this is the left ventricle, right ventricle, so blood flows during systole to the pulmonary artery, so the pulmonary artery dilates and the left side dilates. In X-ray, it's congested pulmonary artery enlargement and cardiomegaly. Degree of shunting depends on the size of the defect relative to the body surface area, the relative difference between systemic and pulmonary vascular distance, hematocrit. Anemia increases shunting because of the blood viscosity. Pulmonary hypertension develops early, within 2 years. Anasarca and cyanosis, Eisenmenger syndrome by the age of 20, if the patient is healthy enough to grow to the age of 20. But some of these patients, they don't survive. There's a failure of growth. TE, we find the location and size of the VSD, relationships with nearby structures like aortic valve and pulmonary valve. Like we said before, maybe there's RCC prolapse, aortic regurg, pulmonary stenosis. Flow direction and gradient of the flow, right ventricular systolic pressure, biventricular function, LV enlargement, RVOT obstruction, associated lesions. This is transesophageal echo, RV inflow, outflow. This is what I was saying previously, that the outlet VSD can be 3 types, either outlet muscular, type 4, or subpulmonic, type 1, just below the pulmonary valve, or if it is related to the tricuspid with no tissue in between, so this is perimembranous, type 2. This is a nice way to differentiate the different types of outlet VSD. This is the RCC prolapse, so blood, when blood flows through the VSD, the right coronary cusp is sucked with the jet of the high velocity of the jet, so the RCC prolapses and narrows the VSD more, and then the prolapse causes aortic regurg. If the VSD is subpulmonic and restrictive, so the velocity of the jet hits against the free wall opposite the VSD and causes hypertrophy with time. This hypertrophy may cause narrowing of the RVOT and causes RVOT obstruction. This is a VSD, muscular. This is also a muscular VSD, if you can see it here. This is muscular also, muscular VSD. This is an outlet VSD. I'm not sure which type, but this is an outlet VSD with the left ventricular dilatation. This is also an outlet VSD. Maybe a muscular outlet, but it's close to the outlet, so it is an outlet VSD. This is also an outlet. It appears to be maybe an outlet muscular or a perimembranous VSD, because I can see there is muscle between the tricuspid and the VSD, and the VSD is here, so it seems to be an outlet muscular VSD. This is also an outlet VSD. This is a perimembranous VSD with an aortic overriding, case of fallow. The overriding appears here, and this is the VSD, and the shunt but here the shunt appears to be left to right, so maybe and we can see the beginning of an acceleration here, so this appears to be a fallow case, but with low gradient across the pulmonary valve, so maybe it's a pink fallow. This is a case of right coronary cusp prolapse through the VSD in an outlet VSD. So if you can see the right coronary cusp is bulging towards the VSD, narrowing it more than it should, because the original size of the VSD is from here, from the annulus to the tip of the defect, but the actual orifice through which the blood can pass is narrower than the length or the diameter of the VSD. So this prolapse narrows more the VSD, causing a decrease in the symptoms of the left-right shunting. So the patient may improve from this condition, but aortic regurg may develop. As you see, there is a high velocity here, the gradient is high, the acceleration is high here due to the right coronary cusp prolapse. This is a restrictive outlet VSD. This is a perimembranous VSD, restrictive. This is perimembranous because there is no tissue between the VSD and the tricuspid. They are closely related. This is an outlet muscular because there is tissue between the tricuspid and the VSD. This is a prolapse, RC, right coronary cusp prolapse. It can clearly be seen here. And this is with an aortic regurg, which is a problem. It complicates the operation. And you can see that the original size of the VSD is this, but the actual size that the blood passes through is very narrow from the prolapse. Okay, so the surgical approach, either direct closure or patch closure. If the VSD is perimembranous or inlet VSD, so via right atriotomy, detachment of the septal-leaflet tricuspid valve and then repairing the VSD, because in in the perimembranous and the inlet, the VSD is closely related to the tricuspid, so we can see it through the tricuspid valve. In mid-muscular VSDs, right atriotomy also, we may reach the VSDs via the tricuspid also. In subarterial VSD via a transpulmonary approach. In interior or apical muscular VSDs via a right ventriculotomy, a risk of conduction disturbances or ventricular dysfunction because of the ventriculotomy. So if we can avoid ventriculotomy as possible, we should avoid it. But if the VSDs are accessible except from this ventriculotomy, so it will be done. Pulmonary artery may be an alternative if the VSDs cannot be closed, like in multiple or Swiss cheese VSDs. Spontaneous closure of the perimembranous or muscular VSDs may occur. Perimembranous from the tricuspid valve tissue. The septal leaflet of the tricuspid may close the VSD or narrow it greatly to become restrictive. And the muscular, they may close by themselves. When the infant grows, they may close by themselves. Weaning from bypass, we give volume and inotropes because of the dilated LV, so we should support it. A heart block may occur. This heart block may occur when the surgeon takes the stitches of the patch that closes the VSD. He may injure the conduction system, so it may occur. Heart block is expected in VSDs, so it can be treated with temporary pacing and hydrocortisone if the condition is caused by septal edema and not a direct injury of the conduction system. If persistent, a permanent pacemaker would be inserted days after the operation when we are sure that the heart block will not resolve. Junctional ectopic tachycardia, JET, may develop treated by cooling to 35 degrees, increasing anesthesia, amiodarone, or overdrive pacing. In general, it is difficult to treat, and all these measures are non-specific and sometimes difficult to achieve, especially if the patient is awake, or maybe cooling is not healthy for the patient for other reasons. So jet tachycardia, the jet is one of the difficult arrhythmias, one of the most difficult arrhythmias to treat. This is an inlet VSD. This is the view from the right atrium. This is the tricuspid valve. This is the inlet VSD behind the septal leaflet of the tricuspid, and this is the perimembranous VSD below the crista supraventricularis. This is the type 2 VSD. The AV node, this is the AV node, and this is the conduction system, the bundle of His. So when the surgeon puts a patch here in the inlet VSD, or in cases of canal closure, canal repair, or in cases of perimembranous VSD closure, like in fallow cases, we expect a conduction defect. We expect heart block. So canal cases and fallow cases, in canal cases and fallow cases, we should expect a heart block, and we should prepare for it with the pacemaker. TE post biventricular function, residual defect, other VSDs that may appear after closure of the main VSD, because if there is a main VSD and a small VSD, so blood prefers to pass through the big VSD, and the other VSD may not appear, or may be closed with no blood passing through, although the defect is present. So when the VSD is closed, the main VSD is closed, so blood will be forced to pass through the small other VSD. So we should look for other VSDs after, before and after surgery. LVOT obstruction and aortic regurg, volume status, and the need for inotropic support. This is the patch after closure of a VSD. We should search for any residual blood passing through the residual VSD passing through the patch. This is also post-closure. In cath lab, usually requires general anesthesia or sedation for complete physical and hemodynamic immobility. These cases are usually younger than ASD cases. Hemodynamic instability may occur due to wire traction on the ventricles. Wires pass through the ventricles, the left and the right, so any traction on the ventricles may distort the anatomy of the heart, or the orientation of the heart and its veins that enter the heart. So this may cause hemodynamic instability during the operation. Heart block may occur, device embolization may occur, arrhythmias, because wires and loops of wires are inside the ventricles. So although arrhythmias also occur in ASD closure, but arrhythmia in ASD closure are atrial, but here all sorts of arrhythmias may occur. Also valve regurg from the device may impair the tricuspid or the mitral valves, so valve regurg may occur. Hemodynamic stability after deployment and smooth extubation without coughing or straining. For all these reasons, I prefer general anesthesia with VSD closure. The PDEs are in their pathophysiology are similar to VSD in many aspects. The PDE is a connection between the aorta and the pulmonary. Usually at the duct, this is ductus arteriosus. This is the usual site for it. Between the left pulmonary artery at the bifurcation and the descending, the junction between the arch and the descending aorta. It should close functionally within 10 to 15 hours after birth due to increase in PO2, removal of placental prostaglandins, release of vasoactive substances like bradykinin and thromboxane, catecholamines, then closes permanently by fibrosis and intimal proliferation and fibrosis, thrombosis and fibrosis and intimal proliferation within 2 to 3 weeks. Sometimes they remain open for congenital reasons and sometimes from environmental. In people living in low oxygen, atmospheric oxygen content, like in high altitudes, suffer from patent ductus arteriosus more than normal because of the low PO2 in their blood. Perioperative assessment, general considerations like before. Assessment of the direction of blood flow and gradient across the PDE. PDE causes left to right shunting during systole, like the VSD, and volume and pressure overload on the pulmonary circulation, causing rapid development of pulmonary hypertension. Left-sided dilatation, full in neonatal pulmonary vascular resistance, worsened symptoms, history of low cardiac output, failure to thrive, congestive heart failure. All these are similar to the VSD. There is a diastolic runoff. So, because of during diastole, blood runs off or escapes through the VSD, through the PDE to the pulmonary circulation with low pulmonary vascular resistance. So the diastolic pressure falls, similar to aortic regurg cases. So with this low diastolic pressure, low coronary perfusion may occur and ischemia. Restrictive PDE is less severe. Prostaglandins keep it open, oxygen, non-steroid and non-steroidal close it. So if you want to keep the PDA opened in PDA dependent cases, we give prostaglandins. If you want, and we don't give oxygen. If we want to close it, we give oxygen and non-steroid. This is a PDA, so blood flows from the left ventricle to the pulmonary circulation, dilating it, and then blood flows back to the left side and dilates the left side. The lung is congested. The pulmonary arteries are enlarged with cardiomegaly. Degree of shunting depends on the gradient across the diameter and the length, and the diameter is more effective. The relative difference between the systemic and pulmonary vascular resistance hematocrit, like the VSD, pulmonary hypertension develops within 2 years, and Eisenmenger by the age of 20. Surgical approach, either give cyclooxygenase inhibitors like non-steroidals and paracetamol, transcatheter closure, thoracotomy or sternotomy to close the PDA. Sometimes video-assisted thoracoscopic surgery, VATS, robotic-assisted total endoscopic closure. Transcatheter closure is the most common, but in some cases we refer to surgery. Intraoperative general considerations like left to right shunts, avoid bradycardia, to decrease the diastolic time, to avoid the fall in diastolic pressure and coronary perfusion. We take the general precautions for thoracotomy, like the lateral position, and avoid applying pressure on pressure and causing bed sores. The ECG stickers should be away from the surgical field. Secure the endotracheal tube, because if during the lateral position the endotracheal tube slips during the operation, it is difficult to re-intubate. Ensure no leak. Ensure that the tube is not endobronchial to the collapsed site, because if the tube is endobronchial at the site that will be collapsed during thoracotomy, the patient may not be ventilated. And if the tube is endobronchial to the other side, that is the dependent site, which is usually the right, this is acceptable, because during the operation the one lung is ventilated and the other is collapsed. Pressure points and good padding. During lung collapse, we open 100% oxygen, low tidal volume, high respiratory rate. We monitor the airway pressure, and we recruit at the end to inflate the previously collapsed lung. Neonatal closure may be done in neonatal ICU to decrease risk of transport, ventilator change, and hypothermia, but this is not our practice, but it can be done if a total antiseptic technique is secured in the ICU. High spinal, caudal, and thoracic epidural may be used, but this is not our practice also. Biventricular function by the TE, RVSP, left ventricular enlargement, associated lesions. Complications, pneumothorax, chylothorax, vocal cord paralysis due to injury of recurrent laryngeal nerve passing through the thorax. Ligation of the pulmonary artery or descending aorta. Sometimes the surgeon may get confused between a large PDE and the pulmonary artery or the descending aorta. So especially during thoracotomy, sometimes the field is narrow and the lung is obscuring part of the field. It is not easy to expose the vessels, so sometimes he may get confused. Measurement of perfusion in the upper limb and the lower limb is encouraged to detect descending aorta ligation. So I may put an invasive in the femoral, a pulse oximeter on the hand, or if I'm putting a radial artery, so I may put a pulse oximeter on the toe in the lower limb, so that once he ligates the PDA, if I find that the pulse oximeter readings stop, so I may alert the surgeon that he may have closed the descending aorta. Consider Marcaine and on-table extubation. Sometimes it's a rapid operation with no complication. Usually it's a rapid, so I may extubate on table. TE post biventricular function, volume status, and need for enteropic support. In cath lab, sedation if no TE is required, general anesthesia if TE is required, heparin on 100 internationals per kg. Complications: air embolism, arrhythmias, thrombus formation on device or applicator, embolization of the device, pericardial hemorrhage and tamponade, transfer to ICU is usually extubated after device closure, hemodynamic stability, smooth extubation, and avoid straining and crying. And that's it for part 2. Thank you.